Imagine you in excruciating pain and no one can tell you what's happening. Genia has been dealing with this since she was very young, and now she's ready to share her story.
So my biggest fear is that, first, the medication that I'm on will stop working. Second, that I won't be able to have a baby. When I was 15 years old, I noticed that my periods had gone from being pretty normal to getting worse, becoming more painful, sometimes excruciating. I got sent to the hospital a few times for cysts in my ovaries that had burst. At that time, because I was 15, they didn't do any kind of internal ultrasounds, they didn't do any really diagnosis, they sent me home. They gave me some T3, sent me home, and called it a day. It wasn't until I was about 18 I started looking into my own pain, and I Googled things, I researched, and the word endometriosis came up. Day to day, it's not too bad. I think I've just got a really high pain tolerance now, and that I kind of learned to just keep going through a lot of my pain. When I was 24, I went to a walk-in clinic because I had severe abdominal pain. Because it was on my right side, they thought that my appendix had burst. So they sent me to the hospital, did all the tests, they gave me painkillers, they gave me Gravol, they gave me everything, and it was all really rushed. And it turned out that I had an endometrioma that was 3 centimeters inside of my left ovary, and another cyst had burst in my right. I went to a gynecologist. She addressed my pain, she addressed my symptoms, and she took it seriously. So it went from being something that was just in my head to something that was no longer in my head and was very, very real.
Can you imagine at 18 years old feeling that level of pain and then having this in your early 20s? So Genia is very young. We want to talk a little bit more about endometriosis. So we've got Dr. Marjorie Dixon here, our women's health. And I know we've dealt with this before, but it keeps coming up again and again. We know Lena Dunham has expressed her frustration with having endometriosis, and we see a lot of women speaking out about it because it's out there and it's happening to women, and a lot of people may not know what exactly is going on.
Right.
So the first thing I would ask you is, how do you know if it might be you, if this is what you're suffering from? What are the symptoms?
So, as a healthcare professional, I see women and they present with pelvic pain. And so pelvic pain is kind of a spectrum, and you have to be a bit of a super sleuth as a physician. You have to say, okay, well, pelvic pain is pain that's lower down. It can be related to your periods. It could be gynecological, and we call that dysmenorrhea, so painful periods.
Okay.
But there are several reasons for painful periods. Painful periods can just be because that's what happens. Your uterus is contracting out blood every month.
Yes.
So it's not contracting out a baby, but it does cause that kind of pain. That's called primary dysmenorrhea.
Okay.
That's because of what happens to the uterus. But there are other organic pathological reasons, other reasons why you can have gynecologic pain. One of the top ones is endometriosis.
What is happening if you have endometriosis?
So endometriosis, by definition, is to have the inside lining of the uterus located what we call ectopically, or in other regions of your pelvis. So imagine the inside of your uterus is stimulated every month to grow and shed. But when it implants in other areas on the outside of your uterus, in the area between your rectum and your vagina, every month it gets stimulated hormonally to grow and shed in all those other places. So it causes excruciating pain and inflammation in your pelvis.
How did that happen? How did it get there? How did it get outside of the uterus?
That's a good question. So there are many hypotheses about why it happens. One of them is that during periods when your uterus is contracting to get out the blood, it flows back the tubes and then gets into your pelvis and gets comfortable in areas in your pelvis. That's called retrograde or backwards menstruation. That's one of them. The second one is metaplasia. So the substance, the coating of the inside of your belly and your pelvis transforms itself, because cells can change. So the cells change into endometriotic-like implants in your pelvis. That's another one. Another one is it travels in your blood system because it's prone to family, so that's called hematologic spread, so through your blood system. And the other one is through your lymph nodes, how your immune system takes care of yourself. So those are the 4 main hypotheses as to where the endometriosis comes from. Regardless, the pain that comes from it and the subsequent inflammation and problems is from these inside of the uterus lining being in the wrong place. So she mentioned cysts in her little segment there on her ovary called endometriomata. It's a big word to say endometriosis cysts on the ovaries, and those can cause a lot of problems, and that's one of the common presentations for endometriosis. So the main presentation, 80% of the time, is pain. So that's one of the, maybe I have endometriosis signals.
So you're having some kind of pelvic pain. You finally go in. You have to basically figure out that this is not normal.
Exactly.
Because she said something very key there. She goes, I think I just have a high pain threshold.
Yeah, and that's what
Hello,
women do.
you're a
Yeah.
woman.
The women do that. We
have high pain thresholds. Like watermelons come out of a hole. So small.
Yeah, but that's...
So you really have to wake up and say, this is not normal.
Well, exactly. And so we know with our periods, and people, I'm amazed at what people will endure.
Yeah.
And the interesting thing about endometriosis is the amount of pain that you feel subjectively is not necessarily related to the amount of endometriosis that's in you.
Oh, really?
So it's a tricky thing to deal with. And there are various degrees of severity of the endometriosis. Some people have minimal, mild, moderate, or severe. And it's when it gets severe that really you need to seek medical attention. But in the meantime, it's normal for primary care physicians or healthcare providers to try the conservative things that can work to help with the pain. So how do people deal with pain? Well, one is they'll give you medication like ibuprofen or an NSAID, non-steroidal anti-inflammatory, because it's inflammation, to try and deal with it. That's the first line. If that doesn't work for 1 or 2 months, you should follow up and then say, you know what, this is not getting any better. Then they may consider hormonal things like hormones, estrogen and progesterone. When you give it in the birth control pill or in a specific way, sometimes progesterone only, it suppresses the stimulation of these implants. So estrogen is what makes your lining grow, and progesterone is like the lawnmower, makes it shed. So the estrogen and progesterone together continuously will keep it quelled. So your brain is not communicating with your ovaries, so you're not getting the cycle of pain all the time.
Got it.
So it kind of shuts down the system to not make the endometriosis grow anymore. And sometimes the cysts on the ovaries can shrink up in response to that hormonal stuff.
Is there any cure for it?
There's not a cure. It's a combination. So another way to treat it is sometimes doing a surgery to excise the lesions. And actually, you don't know it's endometriosis until you have a surgical diagnosis. So it's a pathological diagnosis. Someone has to look at it, the pathologist, under a microscope and say, yes, this is endometriosis. Because it could be other things. You might think someone has endometriosis. You go into them laparoscopically. It's not endometriosis at all. They might have had a really bad pelvic infection or PID. And you see all the stickiness, inflammation, that's adhesions, we call it. But it's really internal scarring that can happen. That can also cause pelvic pain. And then when people have inflammation, it's important for me as a gynecologist to say this, is that we're used to doing the medical stuff, take hormones, take medications for pain, let's cut it out. But there are also lifestyle things that if I didn't see it and the patients get better, I wouldn't necessarily believe that it's real. But an anti-inflammatory diet and lifestyle modification, we talk about this on Cityline all the time, about eating real foods, about eating anti-inflammatory foods, beets, wheats, green leafies, these things, keeping your blood sugars stable, because sugar dysregulation is not good for your inflammatory state. And because it's an exacerbation of inflammation with endometriosis, you can help to manage your symptoms by dietary things as well. There are no big studies, which is why often healthcare professionals, which are Western trained, don't talk about these things. But really, we realize in medicine that it's a whole collaboration of all the things that we can do. So yes, you need to do due diligence, see someone. If after 3 to 6 months of conservative therapy, you're not getting better, you have to advocate for yourself. Someone needs to do an ultrasound. It's easy to do, transvaginal ultrasound, see if there's endometriomata. Sometimes they can see the implants. And if you have pain with intercourse, or your periods are making you throw up, or you have blood in your stools, you have to see someone, because that can be deep infiltrative endometriosis, which is a real problem.
I have to ask this, the baby thing.
Yes.
So can you have a baby?
Absolutely, with assistance from a fertility specialist. However, you need to know silver linings, always silver linings. When you are pregnant, you can get a bit of a honeymoon and a break from the endometriosis because your hormones aren't cycling. So sometimes we tell patients, let's get you pregnant. You'll feel better for a little while.
Oh, wow. What a cool solution.
I know, right? But don't do it if you're a teenager. Not a
teen.
idea.
Dr. Dixon, thank you for that.